Hello guys. So let's evaluate a thyroid nodule. For example, if a patient comes to us in our OPD and when we inspect the patient and examine the patient, we found a thyroid nodule. What the next step should be and how to evaluate and treat the patient. Firstly, when we found a thyroid nodule, we have to order the TFTs and check the TSH level in the TFTs. If the TSH level is decreased, normal, or increased. If it's normal or increased, we have to order thyroid ultrasound. Now, in thyroid ultrasound, we have to check for some malignant features suspecting the thyroid cancer. Thyroid ultrasound, if it's showing some high risk sonographic features like calcifications, irregular margins, internal vascularity, or whether it's showing the low risk features like cystic or spongiform changes in the thyroid gland. Now, if the thyroid nodule is of more than 1 centimeter and has any high risk feature as discussed earlier, or the thyroid nodule is of larger size like more than 2 centimeter, in these conditions we have to check for the FNA biopsy. FNA biopsy mostly will tell us that what the thyroid nodule is, whether it's cancer or not, because these are the high risk suspicions indicating the high risk for the cancer. Now, FNA biopsy, if the FNA biopsy shows the papillary changes or medullary changes, so that will lead us to know the what the type of the cancer is. If this FNA biopsy is undetermined, then we have to check for the genetic mutations profiling, because there are some genetic mutations like BRAF, RAT. So these are some genetic mutations seen in the most of the cancer types of the thyroid tumors that we'll discuss in the thyroid tumors. Now, what if the thyroid TSH is decreased? We have to order the radionucleotide thyroid scan. This thyroid scan is done with the iodine, radioactive iodine type 123, like 123 iodine, and we will check for its uptake. If this iodine is uptaken more, so it's called hot nodule or a hyperfunctioning nodule. If it's hot nodule, it means that the patient is having hyperthyroidism, because if it's hyperthyroidism, the thyroid nodule will uptake the iodine more and will produce the thyroid more. But if it's cold, like if it's hypo uptaking, or if it's hypofunctional, then it means that the gland is working more over on itself. It's not uptaking from outside, and it's like producing more, so there's more risk of the carcinoma. Hence we'll order the FNA biopsy in this case too. But if it's a hot nodule, we'll only treat the hypothyroidism. Now, a twist. Most of the students make a mistake here. When we are ordering TFTs, if the TFTs are T3 and T4 are increased, right? If T3 and T4 are increased, it means we have to go for this thing, because if T3 and T4 are increased, in the feedback loop, the TSH will be decreased, right? So we have to go for this thing. So TSH decreased or T3, T4 increased, we have to go for the thyroid scan. If we find T3, T4 increased and TSH decreased, we have to go for thyroid scan. But if we find T3, T4 normal or TSH or T3, T4 decreased, we have to go for thyroid ultrasound. So get this in mind, T3, T4 decreased, because in most of the cases they do not give TSH. T3, T4 decreased, TSH increased, we have to go for ultrasound. T3, T4 increased, TSH decreased, we have to go for scan. Okay, so this is the whole summary. Now, this radionucleotide thyroid scan is mostly contraindicated in the pregnancies because this is a radionucleotide and this can be harmful for the baby. Now, what if the FNA biopsy turns out for some carcinoma and it's revealing a carcinoma? We have to perform thyroidectomy. The treatment is thyroidectomy. If it's carcinoma, then we have to perform thyroidectomy. Now, this thyroidectomy can be partial or total depending on the extent, size, and the metastasis of the thyroid cancer. It can be partial if the tumor is not aggressive or rapidly growing, or if it hasn't metastasized to the lymph nodes. So we can perform the partial thyroidectomy, and if it has metastasized, we have to go for the total thyroidectomy. Now, how to check for the recurrence? We check for the recurrence through mostly serum, through the serum thyroglobulin levels. This thyroglobulin is produced by the thyroid hormone, and hence it reveals the thyroid thyroid tumor recurrence, right? And but in medullary thyroid carcinoma, calcitonin will be the marker for the tumor recurrence, right? So that's it.